Thank you, Alan. Appreciate the invitation. So the sleeve gastrectomy experience is part of the more of a global SAGES Telementoring initiative, which is called Project 6, and we're going to go over that. So I have disclosure here with Olympus. So bariatric surgery is a dynamic field, and certainly there's a lot of frequent innovation, technique, and technology. For example, the SADI procedure was a single anastomosis duodenal ileostomy. It's a new and upcoming procedure. Endoscopic sleeve. Essentially, we perform a sleeve endoscopically the entire procedure by plication of the stomach, and then certainly new technologies such as the intragastric balloon. So the question is, what is the optimal method whenever you have these new technology or technique come about? How can we actually acquire these skills? Certainly, knowing that a new operation or new technique has a learning curve, and that learning curve is associated with higher morbidity. And what we learned previously from laparoscopic gastric bypass is it can even be associated with even higher mortality during the learning curve. Certainly, education and mentoring process reducing the learning curve and potentially reduce the associated complication. So in 2001, a patient safety organization called FAME, which stands for Foundation of Advanced Medical Education, they gave a grant to multiple surgical society, the American College of Cardiology, the Society of Vascular Surgeons, and various others. And they want to identify what are the optimal process for acquisition of new skill. In that particular study, they were looking at renal and iliac artery stenting. And what they found is the best approach is a three-step approach. Step 1, structural didactics. Step 2, hands-on laboratory and simulation training. And then step 3, on-site surgical mentoring. So as you can see here, majority of us attend SAGES and acquire step 1 and step 2, meaning the structural didactic and learn about the new technique, and also the hands-on laboratory. But a lot of us will go home and initiate a brand new procedure on our patient. We do not think that is the appropriate methods, and step 3 is a very critical part of this learning paradigm. So the advantage of surgical mentoring is that it provides a real-time suggestion and learning. So this required a mentor travel to the mentee institution and actually observe the operation and helps the mentee with the operation itself, reduce error and improve patient safety. For those of you who are in the military, this is term kind of coined it in the military in World War I, where the fighter pilots talks to the one in the rear, I have got your six, meaning that I have got your back, so hence the Project 6 Summit. So some of the limitation, though, for on-site surgical mentoring, even though it's very good for the learning experience, is that it's time intensive, so the mentor actually have to leave his work and actually go to the mentee institution, patient and schedule conflicts, and that can actually occur at any time, even up to the date of the procedure, whereby you can actually have to cancel the case, and certainly there's associated with high travel costs. So SAGE has received a grant from the FAME Foundation, and this grant is to evaluate, similar to the previous study, a modified three-step process. Step 1 is structured didactics. Step 2, again, hands-on laboratory training, simulation training, but we add in their tele-observation, whereby the training surgeon observed the expert surgeon to tele-observation. And then step 3, which is instead of on-site mentoring, it's called surgical telementoring. So the SAGES has defined surgical telementoring as previously defined, which is a relationship facilitated by telecommunication in which an expert provides surgical guidance to a less experienced learner, the mentee, from a remote location. So essentially, this is the project that we went through. The target procedure was laparoscopic sleeve gastrectomy. We established a formal educational relationship between the mentor and the mentee. There are issues with state line licensure, so therefore we pair the mentor and the mentee within the same state, except for the state of Delaware and West Virginia. The primary endpoint of the study was essentially looking for feasibility and satisfaction of the telementoring process. I will not show you the data for this study because this will be presented at the podium on Friday at 4:30 p.m. And this is actually the curriculum. So the didactic is based on the SAGE's Handbook of Bariatric Surgery and the ASMBS textbook for bariatric surgery. And then the mentee will go through a live case teleobservation, followed by live case telementoring. And there's a whole evaluation process of the whole telementoring process. So the definition of mentee is a competent surgeon. So unlike a new procedure, for this particular project, we would like to have competent surgeons who are currently performing sleeve gastrectomy, because if there are intraoperative complications, that surgeon has to be able to manage the complication. In addition, the definition of mentor is a mentor that performed at least 75 sleeve gastrectomy previously and participated within MBSA credit centers. This is just the background of our mentee, 13 practicing surgeon and 3 MIS bariatric fellows from those universities listed there. Of note, there are 1 private practice surgeon from Guatemala and also 1 from Argentina. And this is a list of mentors from Montefiore, UCI, University of Toronto, and also Mass General. So this is the platform we use. It's called the Visitor One, and you can see there, the cart is an internet-based cart. It's actually wheeled into the operating room, so it doesn't have to sit there all the time. You just wheel in whenever you want to do telementoring, and to communicate with the receiving platform. It could be an iPad, the laptop, or an iPhone. And you can see here, this is Aaron from Montefiore watching my case. So you can see the cart sitting there, and he's actually watching the operation on an iPad. So this is the second step of the telementoring curriculum. After the didactics, we proceed with teleobservation. This is another example of a surgeon in Guatemala actually observing the case. As you can see here, he's using an iPad and beaming into the operating room. And this is actually a case of Camacho. Diego Camacho is actually showing sleeve gastrectomy here, but now it's more than just a single observer. He's actually provide teleobservation to 2 different surgical units. So training can occur simultaneously by multiple viewers. And this is actually a vision that I have when I actually beam into the telementoring procedure. So I don't beam in until everything is draped. And you can see here, the case is just starting. And this is the console. We call it the laptop control station. And you can actually videotape that. I can use it as a pointer, and I can also telestrate using the laptop. And this is actually a direct view from the Visitor One. So this is exactly what I'm seeing. So I can control the Visitor One to move left, move right, and actually look at any part of the operative field that I need to look. So you can see the abdomen right there, but now that since he's inserting, I want to see the monitor, so I just move the Visitor One a little bit higher so I can actually see both the operative field and the laparoscopic view. So once everything is in place, meaning all the trocar is in place, then I switch to an S signal, which is purely a laparoscopic view. So this way I will get the same view as the surgeon would in the operating room. And so this is now, the case is starting. You can see here, the actual Visitor One normally sits at either the 3 o'clock position or the 9 o'clock position. We found that to be the best position, because this way the surgeon can actually turn to his or her left and actually can see the mentor. And this is the actual operation itself, live audio and video communication between the mentor and the mentee. And this is a little bit extension of that. So this occurred now just with my iPhone. And you can see this is actually the old iPhone. This is the iPhone 4. So you can actually just get this. It's an app on the iPhone itself. And now I can actually mentor anywhere. I don't even have to be in my office. I don't need that laptop with me. All I need is to beam in directly from my iPhone. And you can see the image is relatively well. And here is, I'm mentoring one of the mentee on sleeve gastrectomy. You can see here, one of the common mistake is really stapling too close to incisura. And you can see the staple is very close to incisura, and that's the reason for leaks and also reflux issue. So as you can see here, I'm counseling the surgeon to actually move away from the incisura. And that's another limitation that we're going to talk about a little bit later, is that certainly there is a relationship between the mentor and mentee, and you kind of have to set that up ahead of time and make sure you understand the boundary, because certainly the mentee might not accept your suggestion. So here are some of the comments from the mentee: that this is a great technology, it's usable platform, it's give the surgeon more confidence, and certainly it is an excellent learning tool. There are multiple limitations to this telementoring program here. There's a lot of logistic limitations, scheduling of cases, delay of cases, and how you communicate the delay to the mentor, failure of the mentee to even attend the case, or the mentor to set up the telementoring equipment. There's certainly time zone differences. The most important technology limitation is really the availability of the equipment. So we only had one single Karl-Storz Visitor 1, and we were able to transport that to multiple institutions, so that's a huge limitation. There's also equipment malfunction, such as the availability of the audio or the S signal. There's some regulatory limitation within the context of this study. We only work within the confine of state lines, so both the mentor and the mentee were within the same state. In addition, there's also an issue of liability indemnification by the hospital. I mentioned a little bit about the educational limitation, inability to control the mentee acceptance of the advice. I think you're going to have to work that ahead of time. And then certainly the financial and business model implication. How do we pay for the mentor time, and also the cost of the surgical mentoring platform? So in conclusion, surgical mentoring is certainly feasible and effective. It provides a convenient educational tool that eliminates the needs for travel by both parties, the mentor and the mentee. But I think there's a lot of work to be done, and we need to overcome a lot of the logistic, legal, regulatory, technology, and also educational limitation. And widespread adoption will require availability of a cost-effective platform. Thank you very much.